All right, let's dive into the really high-stakes relationship between anesthesia and the lungs. For an anesthesiologist, every single breath a patient takes is part of this incredibly complex balancing act. If you get it right, the surgery is safe, but if you get it wrong, well, the consequences can be pretty severe. So let's break down how this all works.
So I'm going to start with a question for you. Out of all the ways we measure how the lungs are working, what is the one single lung volume that becomes the most critical the second a patient goes under anesthesia? Just keep that question in the back of your mind, because the answer is really the key to this whole puzzle.
Okay, so before we can really get into how anesthesia throws a wrench in the works, we first have to appreciate the normal, kind of elegant balance of the lungs when they're just at rest. In a healthy person who's awake, breathing is this beautifully simple equilibrium. It's all about opposing forces in perfect harmony.
And here it is, the answer to that big question. The single most important volume is the functional residual capacity, or what we all call FRC. So what is it? It's simply the amount of air that's left in your lungs after you breathe out normally, without forcing it. It's this perfect point of balance where the lungs, which naturally want to collapse inward, are perfectly matched by the chest wall, which wants to spring outward. It's basically the lungs' neutral gear.
So why do we obsess over FRC? Because it is so much more than just leftover air. This volume, this FRC, is your body's critical oxygen reserve. Think of it like a scuba tank. When a patient stops breathing right at the start of anesthesia, this is the tank of oxygen that keeps their blood saturated. And it's simple, right? A smaller tank means they're going to run out of oxygen much, much faster.
And now, we introduce our agent of chaos, anesthesia. As essential as it is for surgery, it comes in and systematically starts to dismantle that delicate respiratory balance we just talked about. The normal rules of breathing? Yeah, they're about to change, and change dramatically.
So the first hit to our FRC comes from the general anesthetic drugs themselves. They cause the muscles you use to breathe in to relax, the chest wall gets a little floppy, and the diaphragm actually starts to shift upwards into the chest. All of that together shrinks that critical lung volume by about half a liter. Gone, just like that.
And believe it or not, it gets worse. Simply by placing a patient flat on their back, the supine position, the weight of everything in the abdomen pushes that diaphragm even further up. This crushes the FRC by another 0.8 to 1.0 liter. So you add those two things together, and you can see that our vital oxygen reserve has taken a massive hit before the surgeon has even made an incision.
And look, this isn't just a numbers game on a screen. This loss of volume has very real, very serious consequences. The tiny little air stacks in the lungs, the alveoli, they start to collapse. This creates something we call a shunt, where blood flows right past these collapsed parts of the lung without picking up any oxygen at all. And the result? The oxygen levels in the blood start to plummet, and they can drop scary fast.
But wait, there's another player in this drama we have to talk about: closing capacity. Just think of this as the specific point, the specific volume, where the tiniest, most fragile airways start to squeeze shut when you breathe out. And here's the kicker. This closing capacity naturally gets bigger and bigger as we get older.
And this is where it all comes together to create a really critical problem, especially for our older patients. Under anesthesia, their FRC is being pushed down, right? But at the same time, their age-related closing capacity is creeping up. When those two lines cross, when the volume at which your airways start collapsing is actually higher than your resting lung volume, you get airway collapse and terrible oxygenation with every single breath. This is a huge reason why elderly patients are at such higher risk.
And there's one more fundamental change we have to wrap our heads around. When you and I are breathing right now, our diaphragm creates negative pressure, and it pulls air into our lungs. It's a suction-based system. Under anesthesia, the ventilator does the exact opposite. It uses positive pressure to push air in. This completely flips the script on the normal mechanics of breathing and adds a whole other layer of stress on the body.
Okay, so we've laid out the problem pretty clearly. Anesthesia comes in and disrupts the whole system. So this final act of our story is all about how we as clinicians can understand these changes, pinpoint the patients who are at the highest risk, and then actively work to restore control and protect the lungs.
The very first step is figuring out who's most likely to get into trouble. And the evidence is really clear on this. Where the surgery is happening is a huge predictor. Any operations in the chest or upper abdomen are the riskiest. If a patient tells you they get short of breath easily, that tells you they don't have much reserve. And for patients with known lung disease like COPD, we have specific numbers. For example, if their FEV1, that's the amount of air they can blow out in 1 second, is less than half of what it should be, that's a major red flag.
Let's make this really practical.
Imagine a patient with COPD. Their fundamental problem isn't getting air in, it's that they can't get air out efficiently. So if you put them on a ventilator, you can run into this dangerous problem called air trapping, or auto-PEEP. This is where each new breath gets pushed in before the last one has had a chance to escape, and it just progressively overinflates the lungs. Not good.
So our whole game plan for a patient with COPD is about one thing: giving them more time to exhale. First, of course, we pre-oxygenate like crazy to fill up that oxygen tank. Then, on the ventilator, we slow down the breathing rate, and we extend the time they have to breathe out, setting what's called an IE ratio of 1 to 3 or even more. Now, this prevents that dangerous air trapping, but there's a trade-off. We might have to accept a slightly higher level of carbon dioxide in their blood, a strategy called permissive hypercapnia, because protecting the lungs from too much pressure is our top priority.
Now, beyond these specific patient cases, there are a few key strategies, a few go-to tools in the anesthesiologist's toolkit that we use to protect the lungs pretty much across the board.
One of our absolute most powerful tools is PEEP. That stands for positive end expiratory pressure. This is our direct counterattack to that loss of FRC we talked about. By keeping just a little bit of pressure in the lungs at the very end of the breath out, PEEP acts like a pneumatic splint. It literally holds those little alveoli open, prevents them from collapsing, and helps us rebuild that all-important oxygen reserve.
For the absolute sickest lungs, we're talking patients with ARDS, or acute respiratory distress syndrome, we use an even more delicate approach. It's called lung protective ventilation, and the entire goal here is to prevent something called barotrauma, which is just physical damage to the lung tissue caused by the ventilator's pressure. So we still use PEEP, but we combine it with really small breath sizes, tiny tidal volumes, and we put a strict cap on the peak pressure to keep those fragile lungs safe.
You know, it's so easy to get caught up in the technology, the ventilators, and the drugs, but we can't forget one of the most basic factors. As our source material drives home, the location of surgery is a strong predictor. Thoracic and upper abdominal surgeries carry higher risks. It's just a powerful reminder that sometimes the simple mechanical impact of where the surgery is happening is one of the biggest drivers of risk.
So, we've come full circle. We've seen how anesthesia disrupts the lungs' natural, beautiful balance, mostly by attacking that critical FRC. And we've walked through the strategies and the tools we use to fight back. So the question I want to leave you with is this. Now that you understand this delicate balance, how are you going to identify, prepare, and protect your next patient?